So what we were hoping to do today was to kind of get a very broad overview of how to access the right treatment for BDD. And then the majority of the workshop was really going to focus on what does good quality treatment for BDD look like. And also we would love to hear your perspective. And if you have questions during the workshop, please feel free to ask as we go along. We will be around after the workshop as well if you have any questions. And we've got our emails up at the end as well if you want to contact us afterwards. But I hope this is what you were expecting from this workshop, hopefully. I don't know how many, it's hard to know how to pitch this workshop because I think it's probably quite a range of people who might be suffering from BDD, but there might also be some people who are looking or who are relatives of somebody with BDD, and I believe there might be also some professionals. So bear in mind that we tried to pitch it in a way that kind of might answer some of the questions that every kind of person might have in this room, but we might have got it a little bit wrong, and we'll be happy to answer questions you have anyway. Was there anything? Yeah. No? So for those of you that don't know, the NICE guidelines, which are the national guidelines and the international guidelines as well, recommend two types of treatment for people with BDD. One is a talking therapy called cognitive behavioral therapy for BDD. And the other option is medication. They could be done together or it could be done one or the other. And it's a particular type of medication called selective serotonin reuptake inhibitors. We won't be focusing on medication during this workshop. But if you have any questions, obviously we're not psychiatrists, but we'll try and do our best to answer questions if you have any on medications. So first things first, how to access the right treatment. So this is a very basic graph of what would be the standard care pathway. So the first port of contact is always the GP. Going to the GP and explaining what is the main difficulty and this being around appearance anxiety. And a lot of the times what I often advise is people to take some information with them because not everybody is very familiar with BDD compared to other mental health conditions. So if you download resources from the BDD Foundation website and you bring it with you, it might also be helpful for the GP to understand what you're explaining. The GP will make a referral to your local mental health service. That could either be an adult service if you're an adult or a child services depending on your age. And you'll be offered an assessment within the mental health service. They'll check, they'll ask questions about the main difficulties and things like that. And if BDD is confirmed, then you have two options then. They'll either offer intervention locally within the mental health service there, and it should be CBT for BDD with or without medication, because that's the national guidelines. So if you're being offered, if you have BDD, you've been given the diagnosis and they're offering something else, you may want to query that and ask for the rationale. Alternatively, sometimes local services might say, actually, we don't have the expertise, we don't have the resources, or it might be a little bit too tricky, and they might decide to make a referral to the national and specialist services for BDD. So these are services that specialize and work specifically with people with BDD. If you go down that route, then what they'll do is they'll offer an assessment. If BDD is confirmed, they'll offer treatment. You'll be in follow-up. Most of the time, there's often a period of follow-up where you don't see the clinicians there weekly, but it's almost like less contact to see how you get on your own. And then if everything goes well, you get discharged after that. So that's a really broad summary of what the pathway to the right treatment is. Any questions?
Can I just say that I work in an assessment service, so if somebody was referred, I would do that assessment for somebody, but they don't automatically get that diagnosis and they don't automatically get to see a psychiatrist. unless it's requested and it was beneficial for that person. And also, if people do need to go to specialist services as well, they have to be referred by their GP, because there's different funding from the CCG to pay for that specialist service.
So we're going to talk about the patient choice route in the next slide.
Right.
But for these national specialist services, the referrals have to come from the GP, from the CMHT, not the GP.
CMHT.
From the CMHT, yeah.
Or CAMS for children's services.
Right, okay.
Yeah. Yeah. So this is a list of all the national specialist BDD services across the country. So there's only one for young people under the age of 18. That's the one in the South London and Maudsley Hospital. And then there's ADRU, where Anna works in, and there's a range of outpatient and inpatient services. And I suppose this is what you were referring to. There's an option called the patient choice, which is available only for adults, not for children's services.
Yeah, so if you live outside the four kind of South London and Maudsley boroughs, so outside Croydon, Lambeth, Southwark and Lewisham, you can request to be seen at CADAT, which is the Centre for Anxiety Disorders and Trauma at the Maudsley Hospital, which is a national specialist service for that treats BDD. And basically what this means is wherever you live in the country, if you're outside these boroughs, you could ask your GP to refer for specialist treatment there. These are the kind of criteria. So the GP and patient must have discussed and both agreed to the referral to the service, even though they're aware there might be services available locally. The patient's not currently under the care of a CMHT or receiving any other mental health treatments and is not on the waiting list. So if you meet these criteria, then the GP should send a written referral with as much clinical information. The service leader will then triage the referral, and if he agrees, it'll be added to the patient choice waiting list. So this is where your GP can send referrals. So this is an option if you go to your GP and you don't feel that you're getting anywhere with seeking treatment. You can always ask to be referred down to CADAT to London, which is may not be geographically convenient, but they're a very, very good service and they're specialists in treating BDD.
So what does CBT for BDD look like? So bear in mind, services vary. They might provide slightly different protocol. But usually you would expect a certain amount of sessions, so usually between 16 and 22. But again, that varies. Most of the time they're about 1 hour and they're weekly. For those of you who have had experience of CBT for BDD, they might know this already, but it is a pretty active pretty active therapy. It's not about just going to therapy or talking about things. It's about doing things and practicing what's been done in the sessions, in between sessions. So there's a lot of homework and there's a lot of expectations around the level of participation that's required for it. As I said, the treatment protocol does vary. I work for our children's services, so often we have to adapt the treatment to the age of the young person, making sure that, it will be different if I'm treating somebody who's 12 versus somebody who's 17 or 18. We take a much more behavioral approach compared to our colleagues in adult services, a very much more behavioral and concrete kind of approach. And we often try and have parents in our sessions or parents involved in the treatment as much as we can, because we know parents are a great asset in supporting young people in treatment, and also they often can get stuck, or get stuck into the BDD themselves, seeking reassurance and doing other things. So it's important that we want to make sure that they know what they can do in treatment to support their child. Wherever you go for CBT, these are the kind of the key elements that should be there really when looking at the quality of the CBT for BDD. So a few sessions should be spent on what we call psychoeducation. So that's learning about what BDD is, learning about anxiety, and really understanding the person's BDD. So how did it develop? What kind of experiences have they had that led to the beliefs about the appearance that they have? And what keeps it going? What keeps the BDD and the appearance anxiety alive? Once that part of the treatment, so that's usually a few sessions depending on who you're working with. But then the two key elements that we'll focus mostly in this presentation is then exposure work and then cognitive therapy work. So one is more to do with the behaviors that people that suffer from BDD might start doing in response to their anxiety about appearance, and the cognitive therapy is more about the thinking process and some of the beliefs and thinking traps, so we call them, that often are common in BDD. The last few sessions tend to focus on relapse prevention, so really thinking about everything that the person has learned and has done in treatment, and what remains, what are the things that they need to keep working on, but also what to do if there are any lapses or any relapses, so that the person feels confident when finishing weekly treatment that they can carry on and stay well. So I'll cover the exposure bit and kind of explain, because that's the one that we tend to use mostly in children's services. And Anna will give you an overview of the cognitive kind of therapy that takes place in BDD treatment. I suppose before I go into explaining exposure, one thing that I think is important to highlight is that some people might have had treatment in the past, and the treatment for BDD is constantly changing and being tweaked all the time. And as you can see from the keynote speech from Dr. Jassy, it has improved massively over the last few years. So if you have tried treatment in the past and it hasn't worked, definitely reconsider it again, because it might be different. It might have been also a different time in your life. There might have been other things going on. And also the therapist is really important. Sometimes you might not click with a therapist, and it might be that another one might be worth a try, and it might make a big difference. So what is exposure therapy? So the actual name that we use is exposure and response prevention, so ERP. And it's the key treatment component of CBT for BDD in young people. And what it's all about, it's the exposure bit. So there's two elements to ERP. There's the exposure bit, so taking the courage to face your fears and do something that you're either anxious about or have been avoiding, ideally with the body area of concern visible to others. And then the second bit is doing that, facing that fear without doing the BDD safety behaviors, or the things that the people with BDD feel they have to do to try and make themselves safe. So that might be checking the mirror before they leave the house, or doing lots of makeup to cover up their certain features or their skin, or it might be lots of camouflaging. So just to give you an example, an ERP task would be going to the shop, so that's the exposure, and then doing it without wearing a hat. So that's the response prevention. And those two elements are really, they go together. It's not just about facing the fear, it's also doing it without that behavior that keeps the person feeling safe. So these are some of the examples, and I'll ask Elias later on to share with us maybe some of the things that you've done. But we often, in sessions, we might go up to public places with less makeup or with no makeup if the person feels ready. We might practice leaving the house without checking, or without checking the mirror at all, or reducing the checking. We might go to the shop without a hat. We got, all sorts of different things that involve exposure and response prevention. So I can't, and I'm sure that might be your experience, I can't deny this is easy. This is really, really challenging work that is expected a certain amount of anxiety and discomfort. And this is the reason why we do it. There's a very clear rationale behind it. And I'd like you to think about something, a situation or a place or a person or an object that you might have felt really anxious about. And the exposure is based on the principle that if we face that situation and we stay with it and fight the urge to run away or do something to make it better, the anxiety will rise the first time you do that thing. You will feel uncomfortable for a while, but eventually if you stay in that situation, the anxiety comes down on its own without having to do anything about it. And the more you practice facing that same situation over and over again, the less anxious you feel each time, and the anxiety comes down a little bit more quickly than the first time around. So I often use a really silly example just to really take it away from appearance stuff. And I kind of say, you know, imagine I have a fear of roller coasters. I'll go, you know, on a roller coaster, first time I go, my anxiety will go off the charts and it will be really, really high. But if I stick with it, if I say I'm going to do this, it will eventually come down on its own. And if I keep doing it every day, over and over again, eventually your brain and your body just don't register that as a threat anymore. So this just summarizes what I said. The anxiety comes down over time all by itself when you face and stay in that scary situation without doing anything about it. No safety behaviors. And the more we do something scary, the less anxiety provoking it becomes. So that's why we do exposure. That's actually why we see such a big shift. And these are the kind of things that exposure does. First of all, when we do exposure, when the person feels brave enough to do it, the person learns that the anxiety does actually come down with practice. And it's something that they need to experience themselves. We could be saying it over and over again, but it's only the moment that you do it with them and you practice over and over again and they experience it themselves that they really see it and understand it. Often when we do exposures, even if we don't talk so much about the thoughts, sometimes there's a bit of a shift in the beliefs and the thinking that they have. And they find out, actually, I went to the shop and I didn't wear a hat. And I thought people would be staring or laughing or pointing at me, and it didn't happen. So they start thinking, oh, perhaps what I think is going to happen or my predictions are not as accurate as I think they are before I did the exposure. And the thing is that a lot of the times people would have told them, you look fine, nothing is going to happen if you do this, but it's only by doing it and taking that leap of faith that you actually find that out. And often we try and do exposures around the things that the goals and the things that the person values. So a lot of the times we might go to art groups or things that the person wants to do. And not only that's a really good exposure task, but it often builds on self-esteem. And it starts to sort of, they start getting a bit more exposures to things that are not related to appearance and to build on that side of their lives that maybe has been a little bit neglected because of all the space that appearance anxiety has taken over. And the other thing that I often see is that even when exposures are incredibly challenging and incredibly difficult, that often the person actually thinks, yes, it was awful, I did not like it, but actually I tolerated it and did it, and it feels good to have been doing this thing that I've been really, really scared for so long, and it gives a sense of satisfaction. I see a bit of nodding on my left.
No, especially if you start doing smaller exposures and just build up your confidence, and then when you do get to the harder exposures, you think, wow, it doesn't matter how much time it takes, but if you think back when I started, I wouldn't even have thought that I was able to do this, and now I'm doing it, and it really fills you up with confidence to keep going and just keep doing the exposures. And just keep getting better, really, if you just keep at it and keep pushing yourself, really. And sometimes I think it's important to go further than what you would normally experience. So you think, well, why would you need that? Well, because if you know that you can do an exposure and manage to, tolerate the anxiety and tolerate the nervousness of going further than you would normally, then you know that in normal settings in everyday life you'll be totally fine. So I think it's very important not to just stop. It's a bit like when you take a course of antibiotics, you shouldn't stop. When you feel better, you should finish it. So it's the same thing, it's similar. So you should always go a little bit further, just so you know when you go back, you'll be able to tolerate it and you'll be fine.
Well, can I ask you some examples of the kind of exposures you might have done in
Yeah,
treatment?
so basically my BDD issue was with my face. So I used to cover up my face with a scarf and a hat or a balaclava, and I wouldn't want people to see them. So my exposure, I was at the Priory, and my exposures involved going out in London without, I used to put on a lot of makeup, without makeup or with minimal amounts of makeup, and just sort of interacting with strangers, interacting with people. And sort of, you get the idea of, because when you're out on the street, you know, you don't really pay attention to other people, but as someone with BDD, you think, oh my God, everyone's looking at me, everyone is thinking that I look awful, but they're not. And so interacting with them and realizing that the way they talk to you and pick up their body language and going, well, they're open, they're not judging me, really helps. And like Benny said, everyone can tell you, oh, your friends and your family, and especially doctors can say, oh, you look fine, it doesn't matter, it's okay. But if you experience it yourself, and if you build up the confidence to realize, wait, I actually do look okay, and it's just in my head, it's just a thought, it's very important. And doing exposure and repeating it really helps, like you saw in the graph, because the first time is really hard, but the more you keep repeating and the more you keep doing it. And I think another important thing is, even after you've been you've gone after the treatment's finished, you've been discharged, or if you weren't sort of impatient, you've just been, you're now in the follow-up stage. It's always important to keep doing the exposures, and just firstly because it reminds you that you can do it, and it just sort of gives you that sense of accomplishment, and you feel, oh, I can still do it, I've still got it. And also because it really helps just to keep going the streak of just getting better. So what I mean is, basically it just reduces because relapses sometimes happen, sometimes they don't, it depends. But if you keep doing exposures, it really reduces the chance of you getting a relapse, because you know that you're always pushing yourself and you're always going that extra step to keep doing things that you may feel a little uncomfortable, or you don't, it depends. Even if you don't feel uncomfortable, it's good to do them.
Yeah, that's spot on. And we often say towards the end of treatment, we often make the analogies of living the exposure life, where it doesn't become a chore where you do, okay, let's set up a task where we do this and we test that, or we see what happens to anxiety. When you're in the follow-up, is about carrying on, incorporating that exposure into your daily life. And you talked about in our follow-up sessions about how, on days that you might feel a little bit more self-conscious, not that it's a setback or anything, but you might push yourself to go out anyway, or if you feel like there's some, a little bit more self-conscious about the skin, you make an effort to go, even though it would be really easy to stay in because it's rainy or whatever. Yeah. But that kind of chipping away at really putting yourself out of your comfort zone as much as possible, and really your brain registering that actually you can do this, you can tolerate it, and actually a lot of the beliefs around what would happen, often learning what happens, actually testing that out.
I think especially on days when, even if you're better, you don't feel great. I think especially it's really easy to think, oh, it doesn't matter, the doctor said I'm better, I've been discharged, it's okay, I don't need to do it. But I think especially on those days where you don't feel great, you feel a bit self-conscious, you feel like you might be, sort of the behaviours are coming back, always try and do it, try and do exposures, try and do things, especially on those days, because if not, you won't notice it. It's like a parent, they don't notice their children growing because they're growing really slowly. It's the same thing. If you don't push yourself on the days that you don't feel great, then it will keep building, and then one day you won't be able to do the things that you won't because you will have relapsed a little bit. So always push yourself on, especially on those days that you don't feel like it's worth it. But it is. It really is.
So this is how it works. So we, in therapy sessions, we make a list of all the things that the person has to do to fix or hide their appearance concerns, all the things they have to avoid because of their appearance anxiety. And then we pick one. It's a hierarchy, so we'll go from the easiest thing to do to the hardest thing to do, and we pick something in the middle, because we don't want to overwhelm people. We want people actually to come back to our sessions. So we pick something that feels manageable, and we design a very specific task, and the more specific it is, the better in some ways. And then we go out with the therapist and the young person. We go out, we do it. We keep an eye on anxiety. We literally have sheets where we record how the person is feeling over time. And we need to allow enough time for the anxiety to calm down on its own so that the person sees it. See, that actually gets easier. So it might take 20 minutes, might take 30 minutes, it might take an hour. We'll be in that situation for as long as it takes for the anxiety to come down. And then it's really important to reflect back on what the person has learned. What have they noticed? What that they had in before? What happened to the anxiety? And have a conversation about how they found the task. It's therapy assisted. So the exposures are done with a therapist at least the first time of each task, and then they're practiced for homework each day ideally. I usually say at least once a day. The consultants in my team say at least 3 times a day. So I've depends on how much you feel prepared to do. As Elias said, start small. Especially at the beginning, we want to build confidence. So if you start small, and then you can always go a little bit faster later on, or bigger if you want. But it's important to do exposures every sessions and for homework. Practice is probably the biggest advice I have if you're doing CBT for BDD. And this is the final slide before we move on to the cognitive work. But I just wanted you guys to have a think about, or possibly even write down. I've got some Post-its and some pens. I'm going to circulate around if people feel brave enough to think about something they could do, an exposure task they could do today, tomorrow, or have at the back of your mind, completely optional, you don't have to do it. And it might be about appearance anxiety, or it might be something completely unrelated. So I have mine is public speaking without over rehearsing. So I rehearsed only once, and I'm doing a big speech this afternoon with Elias in front of even many times more this audience. So that's my exposure for today. Pick one thing that you feel brave you want to do. Write it down. You can put it on the wall of courage if you like at any point during the talk or after the talk. But as I said, it's optional. And it might be that being in this room is the exposure task, or being at this conference, or having done the journey to come here was the exposure task. And it might be to write down something, might be the exposure task. And remember, it takes a bit of time and it takes a bit of practice. So expect anxiety, it's okay, but it might take a while to calm down, and give it enough time. Very final slide on what's helpful, what's not so helpful. I don't know whether those of you who had CBT for BDD, whether you had any ideas what was helpful or not so helpful?
Can I ask you how you found the homework? Because I know a lot of people I've worked with struggle with that as well. Even though they want to work towards their condition, they struggle with doing the homework, especially being a young person as well.
I think you have to look at it from the sense that it's not something that you're doing for someone else. It's something for you that you're doing for yourself. So I was at a pretty bad place, and I thought, well, I can only get better, and I really have to give it my all to get better. But I know lots of people find it really hard to put themselves in that position. I think a really important thing is to detach yourself from the mental illness. So you have to realize that it's not you. It's not because then if you think it's you, then it leads to sort of self-criticism, and you're criticizing yourself and going, oh, it's all my fault, and it's not, because it's not you. It's a mental illness. It's a bit like if you broke a leg, it's not your fault. So basically, what you have to realize is the first thing is detach yourself, and that makes it a lot easier to beat it, because it now puts you and the people that are trying to help you against something, and it's a concrete adversary that you can feel good about overcoming. But also, yes, don't be afraid to. Don't feel ashamed if you've not managed to do it. Speak to the therapist, or speak to the person that's helping you, because you might feel like, oh, I haven't been able to do it. That's it. I've said I can't be treated, which is not true, because there's always little setbacks, and there's always setbacks really. That it's life, And so if you speak to them and if you go, okay, look, I really tried to do it, but I couldn't this time, I really couldn't, then they'll go, okay, maybe next time we'll do something else, we'll try something different, maybe we'll try to do it in the session and then see how it works out. But I think, especially, yes, trying to look at it, I think the most important thing is you're doing it for yourself. But I know it's really hard sometimes because you feel maybe depression's in the mix as well, or you feel like, you know, there's not worth it doing for yourself. It really is, because it will get better. And that's the most important thing, I think.
Thank you.
I think on top of that, I would also think about, is this task too difficult for them to do on their own?
Yeah.
And I often think about parents, can they help in any way? And sometimes I think when we do the task in the session, it might be easier for them to do it in the session than it is to do it in their own neighbourhood.
Yeah.
And so I might also ask, perhaps that task is too difficult for them, and I might decide to go on a home visit and do the task in their area. See how it goes. I think out of this, the only two things I'd like to say is it's a collaborative process. Exposures are hard. You should not feel that you're being forced to do something you don't want to do. It's about getting you to do the things and reaching the goals and the values you want to achieve in life, and this is just a way of getting there. So you decide how much you want to push, not your parents, not your therapist, not your partner. And the other thing is practice. I think doing things once is just not enough, especially if you suffer from BDD for years. You have to, it's a bit of a retraining your brain in some ways. You have to do it various times.
Okay, so what I'm going to talk about now is more of the cognitive side of CBT. So one of the ideas in CBT is that we're changing our behaviours to bring about a change in our beliefs. So we might have beliefs that kind of maintain some of our difficulties. So there might be beliefs at work that have kind of contributed to the maintenance of some of your difficulties. And therapists will work quite closely with you to understand what those beliefs are and to work out if those beliefs are still valid. And that's not to say they're wrong, but there are some things about these beliefs that we know may not apply now. So you might have beliefs like this: I'll be rejected because of the way my nose looks. And this may have been part of your experience in the past, but the therapist and you should be working together to see if this belief still applies 100% to your life now. And here, just that idea about collaboration, it's really important to remember your therapist won't be telling you what you should or shouldn't believe, but you'll be working together to sort of find out a little bit about the way that the world works. Your therapist might talk to you about something called thinking errors or thinking traps, or styles of thinking. And again, we know in BDD that people have certain styles of thinking that can affect these beliefs. So they might, your therapist might talk to you about things like black or white thinking or catastrophizing. So those kind of things might be coming up in some of your sessions. And Benny's talked a lot about exposure, but just to sort of link it around behavioural experiments. And behavioural experiments provide the opportunity to test out some of the beliefs and predictions that might have been maintaining your difficulties. Again, I'll be sat up with your therapist. You can sort of agree together what kind of beliefs you're going to be testing out. And experiments may take the form of making predictions about how people might respond to you, making predictions about what will happen if you don't use your normal safety-seeking strategies, or making predictions about how you might cope without your normal camouflage. This is an example of a kind of prediction. I predict that if I do not wear my hat, people will make negative comments about my appearance. And your therapist and you will agree how you're going to test this out, and will ask you to rate how strongly you believe this prediction. Following the experiment, you'll sit down with your therapist, you'll talk about what happened, and consider whether this has altered the strength of your belief or prediction. And you might then discuss how to take this forward. So is this going to be another experiment? Do you need to do it in a slightly different way? Do you need to do it in a more busy environment? So each time you'll be kind of adding to that evidence you're building up about your beliefs. There are other kind of modules, I suppose, that might come into more of the cognitive work for BDD. There's something called imagery rescripting that we do. And we know that in BDD it's really, really very common that people have had experiences, particularly in their teenage years, that have been in some way traumatic for them. So it might be they've experienced bullying or rejection or criticism about their appearance. And we know that these things are really quite key in the maintenance and development of people's difficulties. So your therapist might want to explore some of these experiences with you, and might want to kind of tease out how those experiences have impacted on your beliefs as they stand today. And you and your therapist might work together to kind of process and re-script some of the meanings behind these experiences. You also might do something called mirror retraining. It's not unusual for individuals with BDD to use mirrors in a way that's ritualised or unhelpful. Things like standing very close, using little hand mirrors, magnifying mirrors, using mirrors for hours at a time, or not using mirrors at all. So sometimes CBT for BDD kind of focuses on helping people use mirrors in a functional way. So we call this kind of functional mirror use. And you might do some sessions where you're doing mirror retraining. Rumination is another kind of module that might come into your treatment, because rumination is a real kind of key maintenance process in BDD. We know it's very, very common in this condition, and that's the tendency to really kind of think through or think over things over and over again in your mind. It might be past focused or it might be future focused. So for example, ruminating about whether you could have done anything to change your feature of concern in the past, or ruminating about whether any surgery might help you in the future. And you and your therapist might identify kind of strategies that would be helpful, or times when you're more prone to rumination, or ways that they can help you disengage from rumination. Okay, now good quality CBT for BDD. This is a real kind of bugbear of mine, that actually lots of people come to our service and they say, well, I've had CBT before for BDD, but they haven't had specific CBT for BDD. They've had more of a kind of generic, general kind of CBT approach, and that's just not good enough when you're treating BDD. You need a very sort of specific approach. So first point to put there is formulation. So a good therapist will develop with you a shared formulation of your difficulties. Some people come across these hot cross bun models in CBT, and then they're just not kind of specific enough in BDD. So your therapist and you should draw up a really kind of clear diagram of how your BDD is working, what your main safety strategies are, where your attention's focused, whether you ruminate, the impact on your mood. So all those things should come into kind of quite a comprehensive diagram that's specific to your BDD. And it's really important that therapists help with you and discuss the link between the level of preoccupation you have with your feature of concern and the level of distress you're experiencing. So you kind of should be expecting your therapist to be using this kind of language. Therapists should be using weekly outcome measures or kind of regular outcome measures to sort of monitor how you're doing. You know, so it's expected that you might get handed a questionnaire every session to fill out for the next time you come in, and that's really important that the therapist is monitoring how you're doing. And you may wish to audio record your session. So again, a good therapist will discuss with you whether you want to audio record, because actually a lot of the information in the session, sometimes the client can be a bit anxious to take it all in, so actually having an audio recording means you can return to it at a later date and just review all the things that were talked about. So all these things are kind of things you should be looking for to know that the CBT you're getting is good quality. Thank you very much for listening.
I think the one key take-home message that I'd like you guys to take is that there is really good treatment out there and that people respond to this CBT for BDD.